Hello and welcome to my channel. This lecture is to continue the study of the anterior abdominal wall. So let's begin. Um, the inguinal canal, it's formed actually mainly by the external oblique aponeurosis, which forms the inguinal ligament, and the inguinal ligament it goes backwards to form the floor of a canal, which is called the inguinal canal, that will extend from the deep inguinal ring at one end to the superficial inguinal ring on the other end. So it's from ring to ring. So actually it doesn't take all the length of the inguinal ligament. See, it's only this part. Superiorly, the roof is by the lower arching fibers of the internal oblique muscle, together with the transversus abdominis muscle, to form the falx inguinal at the posterior wall of the canal medially, the conjoint tendon, posteriorly conjoint tendon medially, and the fascia transversalis laterally. So actually the posterior wall is formed mainly by the fascia transversalis, but enforced medially by the conjoint tendon. The anterior wall is the skin and fascia and the external oblique aponeurosis, and enforced laterally by the internal oblique and the transversus abdominis. So the posterior wall enforced medially and the anterior wall enforced laterally. And then when the fibers contract, these two parts oppose each other, so compressing the contents of the inguinal canal and closing the deep ring and preventing any structure from coming out, except for the the spermatic cord, of course. Okay. Posteriorly to, in addition to the falx inguinal, we have the reflected part of the inguinal ligament. Remember that part that extends from the right crus at the superficial opening to the linea alba? It forms part of the posterior wall as well. And the contents of the canal in males are the spermatic cord and the ilioinguinal nerve, while in females, instead of the spermatic cord, we have the round ligament of uterus, which is the distal end of the gubernaculum. The gubernaculum is the structure that guided the testis, actually, in males to come out through the inguinal canal, and then it will get atrophied. The ilioinguinal nerve, how it gets into the canal, this is important to understand. First of all, it's a branch of the lumbar plexus and actually comes out as a branch of the iliohypogastric nerve. They both carry L1 fibers. Now at the back and the side, the ilioinguinal nerve pierces the inside of the transversus abdominis and supplies, of course, and runs from between in the neurovascular plane between the internal oblique and the transversus abdominis for a while, and then pierces the lower arching fibers of the internal oblique to become part of the inguinal canal. It continues in the canal inferior to the spermatic cord and comes out of the superficial ring to supply the upper medial thigh skin. So this is the course of the ilioinguinal nerve. It doesn't enter through the deep ring. No, it pierces the transversus abdominis, runs between the two muscles, the transversus and the internal oblique, and then pierces the lower fibers of internal oblique to become part of the inguinal canal. Okay, this is the ilioinguinal nerve. This is not the way it comes to the canal, of course, in this drawing. It comes from after piercing the lower arching fibers and supplying it, actually. It's essential for the shutter mechanism, and along its course, it's liable to injury especially in McBurney's incision in appendectomies, either by the scalpel itself or by the muscle splitting that follows the cut in the skin. Okay, in the inguinal canal, we'll find the spermatic cord. To understand how it was formed, actually, beyond the deep ring to the inside, there is no spermatic cord. All structures either come from their own sources or going to their own destinies, like the vas difference, for example. But together it's assembled at the deep ring and descends to the testis and its compartment in the scrotum, and the left spermatic cord is slightly longer than the right one. That's why the left testis is slightly at a lower level than the right testis. Okay, what are the contents of the spermatic cord? The ductus deferens, which comes from the epididymis as continuation of the tail of the epididymis and ascends to enter the abdomen, and then goes behind the urinary bladder and to join the seminal vesicle there and open in the ejaculatory duct. So this is the vas deferens coming from the outside to the inside, opposite direction in the inguinal canal. It takes its artery with it from the inferior vesical artery. There's the testicular artery, the artery that will supply the testis, that comes out of the side of the aorta, level of L2, below L2 vertebrae, below the renal actually. And they are called gonadal vessels. Pampiniform plexus of veins, which is a plexus of veins around the testicles that coalesce into 4 branches and then 2 branches and 1 branch, which is a testicular vein going to the left side to the left renal vein, and on the right side goes to open into the inferior vena cava. This is the gonadal vein of the male. The cremasteric artery, the artery for the supply of the cremaster muscle, and it comes as a branch of the inferior epigastric, together with the nerve supply of the muscle, which is the genital branch of the genitofemoral nerve that also enters from the deep ring and exits from the and supply the cremaster inside the spermatic cord actually. The sympathetic and lymphatics around the coverings of the cord and around the vessels to supply the cord and the testicles, and the remnants of the processus vaginalis. Now, instead of learning the layers by heart, external spermatic fascia, cremasteric muscle, internal spermatic fascia, and tunica vaginalis, it's better to understand how they were formed. The testis was inside the pelvis, lateral pelvic wall, and descends, guided by a structure called the gubernaculum, guiding it through the deep ring, through the canal, and throughout the superficial ring. But please, before entering the or invaginating the first layer, which is the transversalis fascia, to take a sleeve with it, it pushes a double layer of peritoneum in front of it. This is called the processus vaginalis. It will descend, continue its descent related to the testis anterior, covering the anterior and sides of the testicles, leaving the posterior part bare. It's a double layer of peritoneum, double layer, and pushed by the testicle as it descends through its course from the ring to ring. Okay, so together the testicle and the processus vaginalis take a sleeve of the transversalis fascia that will form the internal spermatic fascia, and together with the sleeve of the fascia, it takes fascicles of cremaster muscle from the internal oblique as it passes by, and then together with the cremaster it takes a sleeve of the external oblique aponeurosis as the external spermatic fascia and descends to its compartment in the scrotum. Okay, so these are the coverings of the spermatic cord, and to know the fact that beyond the deep ring there is no spermatic cord. Every structure was separate. Okay, so this is how the spermatic cord was formed by the descent of the testis. Of course, there's a case called cryptorchism in which the testis is arrested either by the deep ring in the canal or at the superficial ring, and in either case it's pre-malignant, because testicles cannot perform in the high temperatures of the body, and it's precancerous, actually highly malignant, so it must be dealt with surgically, the cryptorchism. Okay. For the scrotum, it's a pigmented skin bag hanging between the legs, lower down, and it's an overgrowth and continuation of growth of the labia majora in the fetus. If the fetus is destined to become a male, so the estrogens will increase in levels and stimulate the continuation of growth of the genitalia. The labia majora will become the scrotum, actually, with a midline raphe that connects to the ventral aspect of the penis and back to the perineum. The layers of the scrotum are the skin, and then the continuation of Camper's fascia. Remember, Camper's fascia, it becomes dartus muscle, which is supplied by sympathetic supply in the wall of the scrotum. And all the layers, by the way, extend into the septum except for the skin. This was a multiple choice question about the layers of the septum of the scrotum. Okay, remember that the left compartment is slightly lower than the right compartment. So actually, the weight of column of blood on the left side is heavier than on the right side, especially when the left vein, testicular vein, opens in a perpendicular, in a right angle with the left renal vein. So the back pressure will be greater on the left side than on the right side. That's why varicocele is more common on the left side, which is varicosity of the veins, dilation of the pampiniform plexus, tortuosity of the veins. And it feels like, when you examine under your gloves, it feels like a bag of worms. This is characteristic of the varicocele. Instead of the spermatic cord in the male, there's the round ligament of uterus in the female, which is the distal end of the gubernaculum, and it's a cord-like structure that turns into strands distally, and it's attached to the back of the labia majora, and runs with the ilioinguinal nerve, the same like the spermatic cord with the ilioinguinal nerve to its inferior side. So that was about the talk about the inguinal canal and how it's formed and the structures passing through it, and especially the spermatic cord and how it's formed and layered. Now for the blood supply of the anterior abdominal wall. Pardon me for this primitive sketch, because I couldn't find, of course, a complete plate with all the blood supply of the abdominal wall. So I improvised. The abdominal wall has a superficial and deep supply. Superficial supply, for example, comes from the intercostal vessels. The lower intercostal vessels that appear in the anterior abdominal wall and supplies the abdominal wall down to the symphysis pubis. And remember the musculophrenic branch, the terminal branch of the internal thoracic that supplies the higher levels of the abdominal wall. by the superficial epigastric artery. Now the external iliac artery, out after it crosses the from underneath the inguinal ligament, it becomes the femoral artery. The femoral artery, once it begins in the thigh, it gives off superficial branches like the superficial epigastric, the superficial circumflex iliac, the superficial and deep external pudendal. External pudendals, not internal pudendals. Superficial and deep to what? To the spermatic cord. Superficial and deep external pudendals, superficial epigastric, superficial circumflex iliac. These are superficial branches that supply the lower part of the anterior abdominal wall, while the deep supply comes, for example, from the other terminal branch of the internal thoracic, which is the superior epigastric, that enters the rectus sheath from above and behind the rectus abdominis, to anastomose behind the rectus abdominis with the inferior epigastric, which is a branch of the external iliac. You also have a deep branch, deep circumflex iliac, that's parallel to the superficial circumflex iliac of the femoral, running on the inside of the abdominal wall that supplies the abdominal wall. And of course, do not forget the intercostals, as they supply the abdominal wall and muscles, the skin and muscles. Okay, the veins follow the arteries, except for these superficial branches. Instead of draining into a femoral vein, no, they drain into the great saphenous vein, the great vein of the thigh, coming from the foot, actually. It's the longest vein in the body, the great saphenous vein. Lymphatics of the anterior abdominal wall, high above the umbilicus, goes to the parasternal and axillary lymph nodes, and below umbilicus goes to the superficial inguinal lymph nodes, a T-shaped collection of lymph nodes here, and we will study in details with the thigh and femoral triangle. So this is about the arterial supply, venous drainage, and lymphatic drainage of the anterior abdominal wall. The innervation comes from the intercostals in zones, dermatomes, but remember that T7 is parallel to the costal margin, then T8, then T9, T10 passes through the umbilicus, the dermatome that passes through the umbilicus, then T11, T12, and L1 laterally, and reaches to the symphysis pubis. Okay, so this is the zonal supply, actually, of the anterior abdominal wall. We talked about the iliohypogastric and the ilioinguinal. They resemble the L1 fibers. Iliohypogastric, that will supply this lateral side here. Ilioinguinal, that will continue and supply the upper medial thigh. The genitofemoral nerve, we said it has a genital branch for the cremaster, and the femoral branch that will supply the skin over the upper medial thigh and the skin over the femoral triangle, as we will study in the thigh. Don't forget the major dermatomes, please, that T10 passes through umbilicus, T7 parallel to the costal margin. All these come exactly as is in multiple choice questions. I'm bringing you information that will cover, I hope, different kinds of multiple choice questions that you will encounter in your practice. Okay, this plate is to show you the intercostal nerves as they supply the abdominal wall, muscles, and skin. See how they end up in the rectus sheath, supplying the rectus abdominis muscle from the lateral side and actually piercing the posterior wall of the rectus sheath. See? Okay, this most probably T11, this one. Okay. This is how it supplies the anterior abdominal wall. Now let's talk about some clinical cases, like, for example, divarication of recti. This happens especially in women with frequent pregnancies, multiple pregnancies. This weakens the abdominal wall, and since the linea alba is wider high above between the rectus abdominis upper parts, so it's most liable to get stretched and from the continuous pregnancies, and something herniates from the inside, either a coil of intestine or a loop of omentum, anything that can evaginate the weak spot. How do you examine for it? You ask the patient to sit up from a recumbent position. As the woman sits up, you will see a bulge between the two recti. So this is a sign of divarication of recti. Of course, it's surgically correctable. Now, another case, hydrocele versus varicocele. We talked about varicocele, which is varicosity of the pampiniform plexus of veins. Hydrocele is accumulation or fluid between the two layers of the tunica vaginalis, which was before the processus vaginalis. Okay, either due to trauma, for example, or infection, or even a hematoma from a bleeding cancer, or from trauma. It makes a swelling that you can localize to the anterior and sides of testicles only by examining using your two hands, and not the sensation of bag of worms like you get with the varicocele. The hernias. We have different kinds of hernias, external hernias and internal hernias, but we will mention some examples here, like the famous inguinal hernia, the direct and indirect type. Now, inguinal hernia means it's in the inguinal canal, and it will emerge from the superficial inguinal ring, and it may go and actually eventually goes into the scrotum. So it's directed downwards and medial into the scrotum. Okay? The direct type is whatever invaginated the wall did not come through the deep ring. No, instead it invaginated or pushed its way from the posterior wall. Okay, this is the direct hernia, and it usually happens in this area here. This is called the inguinal triangle, or the Hasselbalch's triangle. It's bounded medially by the lateral wall, lateral border of the rectus abdominis, laterally by the inferior epigastric vessels. Remember, they are medial to the deep ring, of course. This is the position of the deep ring. And inferiorly by the inguinal ligament, this triangular area. Sometimes, by the way, a type of direct hernia that herniates at one side into the triangle and the other side through the deep ring. This is called pantaloon hernia, a type of mixed hernia, direct and indirect, and actually you don't know the type of hernia, inguinal hernia, unless you see it yourself in the surgical field by examining the relation with the inferior epigastric vessels. If the inferior epigastric vessels were lateral to the hernia, so it's a direct hernia. If the inferior epigastric vessels were medial to the hernia, so it's an indirect hernia that went through the ring, through the canal, and out of the superficial inguinal ring. This is the indirect hernia. Now, this is different than, for example, a lumbar hernia that occurs between, see this triangle here formed? It's by the posterior border of the external oblique, anterior border of latissimus dorsi, and the iliac crest. See this rather weak spot here? The floor is the internal oblique muscle, the floor. So it's a rare hernia, but some inside structure might loop out of this defect. It's called a lumbar hernia. Another famous hernia is the femoral hernia. Now, this, as you see, the right hip from below, this is the inguinal ligament. This is the femoral vein, the artery, and the nerve. Medial to the vein and lateral to the lacunar ligament. Remember the lacunar ligament we talked about the past time? The lacunar ligament. This is the lacunar ligament. So I'm talking about this area actually. This is called the femoral ring that continues down in the thigh as the femoral canal for a short distance, vertically downwards, not medially towards the scrotum. And it's smaller in size actually, and more liable to complications because of the narrow space of the femoral canal. So this is the femoral hernia. How to differentiate between it and the inguinal hernia. Okay, we have other types of hernia, like incisional hernias, for example, in old scars in the abdominal wall, previous surgeries. Paraumbilical hernias and around umbilicus, especially with patients with history of chronic cough. Chronic cough that leads to weakening of the abdominal wall, especially if it's in an obese patient. Because in obese patients, the fat infiltrates the tissues and the muscle tissue becomes weaker. Umbilical hernia, usually congenital with fetus born with an umbilical hernia, part of the gut is protruding through the umbilicus, and it can be surgically corrected, of course. Another type of hernia, rare hernia, is called the Spigelian hernia. Spigelian hernia is herniating of omentum or loop in the between the arcuate line and the rectus abdominis. Remember the arcuate line formed by the fibers of the transversus abdominis. This is a site of hernia too. Any pouch or recess inside is susceptible to be subject to be a type of internal hernia actually. Now, another famous question about the groin, which is differential diagnosis of a mass in the groin. Of course, at this level for studying anatomy level, multiplicity marks lymph nodes. The first thing to say about masses, a mass in any part of the body, if it's a multiple mass, so it's more liable to be of lymph nodes origin. You can listen to it by the stethoscope if there is a borborygmy, which is sounds, intestinal sounds, so it's a loop of intestine coming out. If it's reducible, it's a loop of intestine or omentum coming out. And it can be reducible. Reducible is a character of hernia. Reducibility. If it's pulsating, so think of aneurysm, of which artery of course, the femoral artery nearby the inguinal region, and if it's solid, think lipomas, for example, superficial structures. So. Anyway, by using your anatomy, you can it assists you in identifying the type of lesion or mass in the groin. Okay, last thing we're talking about the abdominal wall. I'll show you some incisions. Actually, we have what's so-called the tension lines of the skin. They are transverse in the abdomen, wavy in the abdomen, okay, and around umbilicus. And the longitudinal incisions leave scars more than the transverse incisions because the transverse is parallel with these tension lines, so there's no tension actually on it, on the edges of the wound itself. For example, we have a subcostal incision. This is famous for the, if you are operating on the liver or the biliary tracts, the gallbladder and the common bile duct and such. We have the rooftop incision. This is used to explore the upper abdomen at both sides. There's of course the midline incision that curves around the umbilicus, and this is done in the linea alba, and we studied before that it's preferable by some surgeons, but because of the less bleeding, but it takes longer time in healing because of course of the less vascularity. So, and some prefer the paramedian incision, as you can see here, paramedian incision. This is the famous McBurney's incision. It passes a point at the junction of the lateral 1/3 and medial 2/3 of a line drawn between the umbilicus and anterior superior iliac spine. See, the lateral 1/3 and medial 2/3. The junction is the McBurney's point. It marks the base of the appendix, actually. Surface anatomy of the opening of the appendix, the base of the appendix. Okay, not the appendix itself is variable, of course, in position, as you will study in the large intestine. Now, the phalangeal incision, the suprapubic incision, is the common incision used in surgical sections, working on the uterus and deliveries. And inguinal incision, of course, at the site if you are working on an inguinal hernia, to fix especially the posterior wall where the deep ring is. Okay, by applying a mesh or plicating layers to each other, you work through this incision here and here. So that was all about the anterolateral abdominal wall. I hope you got the maximum benefit of these two lectures about the anterolateral abdominal wall, and I wish you all the best, and thank you very much for watching.